So now that you've heard a lot about all of the apps that you can use for taking care of patients, I'm going to focus more on how do we get our trainees to the point where they can take care of patients, where they can take advantage of all of this great technology that's out there. Specifically, how do we get them autonomous in the operating room? So I do have a couple of disclosures for this. I am involved in development content production for Swish Surgery, which is one of the apps we're going to talk about. I also sit on the board of directors for the PLSC, which is the Procedural Learning and Safety Collaborative, a group of over 50 training programs that are working together to build autonomy and to investigate ways to better train residents. I make no money from either of these apps. Very poor planning on my part. My other disclosure as I start this is that none of these apps are a magic bullet. We are not going to show you an app that will magically create autonomy among your residents. What I do want to talk about is what's available that can facilitate it, as well as the best ways to use some of these apps to enhance autonomy. So there are two things we can do with autonomy. The first would be to simply measure it, but probably the more interesting way to think about it is how do we create autonomy? There's really only one validated scale out there that looks to truly measure the progression to autonomy, and this was developed by Jay Zwischenberger, who happens to be my chair at the University of Kentucky. It's a 4-step scale, pretty simple and intuitive. Starts from the least autonomy at the bottom, which is show and tell. It's just what it sounds like. The attending does the case, the resident helps, watches, learns, the attending is obliged to teach as part of this and to talk through their thought processes. The next step up is active help, and if we think of the operation as a dance, this is a dance where the attending is leading the dance. The attending is directing the flow of the case, but the resident is the one actually doing the steps of the operation. This is often described as the Bovie on my right angle phase, which is unfortunately where a lot of people will spend the majority of their time in training. The next phase is passive help. This is where the dance switches, and now the resident starts to direct the flow of the case and control movement from step to step. And then eventually we'll hope they get to supervision only, whereas the attending, I'm really only there to keep the patient safe and help the resident as they need it. My goal is to intervene as little as possible to maintain patient safety. There are a couple of apps that have been specifically developed to measure autonomy. SIMPL, which was developed by the PLSC, and Swish Surgery, which was developed by a group of thoracic surgeons. And these use that Swish scale to measure autonomy in the operating room. That being said, these apps aren't magic. There are plenty of other apps out there that are used for evaluating residents that you can build any scale you want into. So if you're using New Innovations or MedHub or any of the other evaluation or milestone apps that are out there, most of them have an ability to customize scales. So if you wanted to put the effort into it, you could build an autonomy scale into any of them. Just to give you an idea of how these work, this is from the Swish Surgery app. At the end of the case, the resident opens the app, starts a new case, and we ask them to enter in a little bit of information. When did they do it? Who did they do it with? What did they do? And then they get to evaluate how much autonomy they think they had. Once they've entered all of this data, which takes about 30 seconds, they then send a text message to the attending. So the app automatically sends this message out to the attending to say, hey, your resident has started this evaluation, please finish it. So now I get this text message with a link on it that I can click on that directly opens into my pending cases. From there, I can click on the case. I see the case that the resident put in. So this was a lobectomy done on January 2016. It gives me the options to fill out how much autonomy do I think the resident had, and probably most importantly, to give some feedback for the resident, just a simple little one-liner about what they did well, what they could do better, something to help them grow. And then when I've done that, it automatically sends a text message back to the resident to say your evaluation has been filled out, you can look at it. So having spent a number of years looking at this data, what have we learned from it? Well, we have some validity data. Does this scale make any sense? It seems it does. The higher the resident is in training, PGY5s get more autonomy than PGY1s. That makes us feel much better about both our training and our scale. We've also looked at the autonomy in relation to the difficulty of the case, and easier cases get more autonomy. This also intuitively makes sense. We've learned some interesting things. We've learned that even for simple, straightforward operations, laparoscopic appendectomy is one of the most common operations done by residents in training. They do not reach the amount of autonomy that we all wish they would. So when we ask both faculty and residents what are their expectations for how much autonomy a resident should have with this type of operation at each level of training, the reality, the blue line here, is always less than the expectations. And it's not just lap appies. The more complex the case is, the bigger the gap between where we are and where we think we should be. So how can we then use these apps to make that switch, to take the autonomy we've measured and actually create more with it? And there's a couple of different models out there. This is my favorite to work with because it's simple. There's really 3 parts to thinking about how to create autonomy. What do you need to do before you get in the operating room? What do you need to do in the operating room? And what do you need to do after the case is over? Beforehand, we need to actually talk to our residents. And with things getting busier and with us pulled in more different directions, with our residents having more computer work, more floor work, more things to take care of, this has become less common than it used to be. But it's really important to talk ahead of time and figure out, where is this resident starting? Is this a case they've done a dozen of, or is this a case they've never seen? Is this a case that's right in their wheelhouse, that it's a simple, straightforward procedure, or is this something that makes you worry before the case? And then in the OR, there's some tricks that you can use to enhance autonomy. So one of them is, instead of telling the resident what to do, build autonomy by giving them that space to think. Ask questions instead of saying the next step is, what is the next step? That forces them to make that shift from doing what you tell them to actually controlling the flow of the operation. It's easy when we're struggling or when our resident is struggling in the operating room for me to switch sides of the table and take over the operation. That's the most expedient way to fix the problem. It keeps everyone safe. It gets everything done quickly. I can move on to the next case. It's a lot harder to tell someone what's going on in your mind. And this is a skill that can be learned, how to teach in the OR, how to describe what you're seeing in a way that the resident can then do things. They often can't see what we can see, and they can't read our minds despite our best efforts, so we need to work on learning how to do that. And again, it's much easier to take over the case if they look like they're struggling, but we have to remember that there may be parts they'll struggle with and parts that they won't struggle with. There may be parts that we will struggle with. Planning ahead of time can help. This part of the case is what we're going to focus on today. If you're doing a lap chole with an intern, you don't expect them to get the critical view of safety, but maybe today our goal for them is going to be focus on taking the gallbladder off of the liver bed. Something straightforward. They know where they're going to get autonomy. You know where you're going to give them a little more time to work. But recognize that there may be parts of the case that you feel like you have to do, and having that discussion beforehand can really help everybody. And then when you do get to a hard part of the case and you need to take it away from them, remember that you can give things back. Just because you switch sides of the table doesn't mean you have to stay there. You can turn the operation back to them to do some of the easier parts. And we can do a lot of faculty development around this. One of my favorite is the idea that an operation must be done either by the resident or the attending. Operations have natural flows and pieces, and if we can break our operations into pieces and talk about what are the easy pieces, what are the hard pieces, that's a great faculty development opportunity to get everyone in a group together and talk about it. The other thing that we can do with faculty development is ways to teach. I mentioned, how do we get a resident to see what we're seeing? Well, sometimes it's as simple as, no, go to the left. Well, is that the patient's left? Is that screen left? In my world, which is thoracic surgery, Our screen is often 90-degree flipped because our patient's on their side. So trying to get that frame of reference. And this is something that I actually teach using Legos. You can create little Lego figures and have people work on describing them to each other. How do you orient the blocks? How do you turn things in space? It's a great way to talk about giving directions. And then finally, after the operation, the residents, again, can't read your mind. They have to know what they did right and what they did wrong. And the app can help with this by giving that little one line of feedback. And when we look at what feedback is given through these apps, thinking about the feedback you give at the end of a month rotation, 90% of it plus is completely useless. It's usually something along the lines of did a good job, appropriate for level of training, or read more. Those are my 3 favorite things to see on evaluations. But when you're doing it every day, just a one-liner at a time, the quality goes way up. So summary of what I've talked about. The apps are many that can do this. There's a couple that are specifically designed for it, but the key is really to measure what you're giving, talk about it, plan for it, create it, and then use that feedback to perpetuate it. And hopefully if we do that, we can create this dream of autonomy throughout all of our programs. Thank you.
Thank you so much.